Good morning, everybody. As always, just giving a moment for everybody to join the webinar. I just wanted to briefly say this is one Grand Rounds talk that I've definitely been looking forward to for a long time. As many of you know, this is the talk about GLP-1 agonists. Big topic, Ozempic. I'm sure most of you know GLP-1 agonists, but most people call it just Ozempic now. Such a been important, probably one of the biggest topics in medicine in the last year. So we're really excited. Before we talk more about our presenter today, we do have a few updates. So I will start by turning over to Dr. Salas. As always, thanks for being here with us this morning. Dr. Salas, turn it over to you.
Thanks so much, Dr. Ozdalga. And I'm afraid y'all are going to get tired of hearing this announcement. I'll be making this announcement for the next several weeks. We are launching a culture and demographic survey on January 30th. That's for our department and the Department of Pediatrics. We're doing this jointly, the two largest departments in the School of Medicine. And this is basically a pilot for what might be a school-wide survey afterward, depending on how this goes. But more importantly, this is going to give us, our two departments, information on our own departments and how things are going and how people are feeling, and also who is in our departments even, because we don't get very granular demographic data from things like the university-wide surveys that have taken place. So again, we'll be launching that January 30th. There'll be an email in your inbox, and then we will send a couple of reminders. So the survey will stay open for a couple of weeks. Please do keep an eye out for that. And, if you have any questions about that, as always, feel free to contact myself, Dr. Dunn, Dr. Harmon, or Dr. Caceres, or our support team, including Winona Alba. And with that, I'm going to turn it over to Dr. Dunn.
Thank you, Dr. Salas. I won't get sick of hearing about that survey, and we'll continue to encourage people to fill it out when they see it in their inboxes. I just want to remind everyone that this February, Black History Month, we will be, as we have done for the past several years, kicking off the month with a wonderful lineup of folks, all Black speakers for the month of February. And we hope that you will come out and see these incredible folks talk to our department. We kick it off with Dr. Chris Flowers from MD Anderson. He is also a graduate of Stanford Med School and gone on to do amazing things. So he will be in person on February 7th. That will be followed by a special Valentine's Day presentation by Dr. La Princess Brewer from Mayo Clinic. She is a cardiologist, aptly so. And then our very own Dr. Robert Fairchild will be talking to us on February 21st. And we'll round out the month with Dr. Kamani Paul Emil from Fordham Law School. She is a lawyer and will be talking to us about how racism affects us on from a legal standpoint in medicine. So please join us then. I will turn it back to Dr. Ozdalga.
As always, thank you very much, Dr. Dunn, Dr. Salas. As many of you know, a lot goes into preparing our February Grand Round month. So please do join us. We have a lot of some wonderful topics excited about. I want to briefly mention next week we have Drs. Upi Singh and Linda Jang talking about the official title doesn't come, but they'll talk about the RECOVER trial, a lot of stuff related to post-COVID. So we'll get the official title. We'll be on Zoom next week, but our own professors will be presenting on that. So looking forward to that as well. And without further ado, special thank you for Dr. Sayal presenting today, and Dr. Kramer, who will be introducing her. Again, she's our own in-house expert on GLP-1 agonists, so we've been really excited for this one. Dr. Kramer, thanks so much for introducing. I'll turn it over to you.
Thank you, Errol. It's my pleasure to introduce Dimpi Desai. Joy Wu, the division chief, is away, so I have the opportunity to introduce Dimpi. Dimpi went to medical school in Mumbai, India, and came to the US to do medicine residency at Jacobi and Einstein in New York. She followed that up with clinical endocrinology fellowship at the University of Pennsylvania, and then went to join the faculty at Baylor as an assistant professor for a couple of years. And in 2022, was recruited to Stanford as a clinical assistant professor, where she focuses on diabetes and obesity. in the outpatient and inpatient settings. And she's going to talk today, as you've already heard, navigating GLP-1 agonists, a comprehensive journey through past, present, and future perspectives. Dimpi?
Thank you so much for the introduction, and thank you so much for having me here for this talk. So I'm going to now share my screen so we can get started. I hope you can all see my screen. And with that, I'll begin my talk on GLP-1 agonists today. And as we've all heard a lot about it the last year specifically. I'm going to focus today to talk about the mechanism of action of this class of drugs, the timeline, some landmark studies about the efficacy and safety, the adverse events that we see clinically, and some future developments. So glucagon-like peptide receptor, GLP-1 receptor agonists have represented a paradigm shift in the treatment of type 2 diabetes and obesity. And the incretin effect induced by GLP-1 agonists allows for glycemic control in a glucose-dependent manner more efficiently and without the risk of hypoglycemia. So what is an incretin effect? So this is an effect, it's a phenomenon where glucose that's delivered orally produces a much greater insulin secretion than the same glucose load that's given IV. So this incretin effect was first described in the 1960s. Initially, we thought that the increase in blood glucose is the primary stimulus for the secretion of insulin by the pancreas. In 1960s, there were some doubts about the efficacy of hyperglycemia alone as a beta cell stimulator, whether or not islet cells are physiologically stimulated by substances other than glucose was disputed. So they conducted a very simple experiment where they delivered glucose orally as well as IV, and they found out that glucose induces a greater insulin response when introduced through gastrointestinal tract than injected intravenously. And hence they concluded that a humoral substance is released from the jejunal wall during glucose absorption, and this stimulates the release of insulin from the pancreatic islet cells. So this was called the incretin effect. And so this human GLP-1 is the hormone that's secreted. So it's a 30 amino acid peptide that's secreted by the intestinal L cells. It's an incretin hormone that increases insulin secretion in response to a meal. GLP-1 receptors are located in the islet cells of the pancreas, in the central nervous system in the brain, cardiovascular system, and other organs. And it is metabolized by the enzyme dipeptidyl peptidase 4, also known as DPP4. The activation of GLP-1 receptor on the beta cell here on the pancreas increases glucose-dependent secretion of insulin, improves the beta cell sensitivity to glucose. In addition, GLP-1 also acts on the stomach and intestine and causes decreased gastric emptying. It decreases the motility of the stomach and the intestine, thereby delaying gastric emptying and reducing postprandial plasma glucose exertions. Brain-derived GLP-1 acts as a neurotransmitter and can target multiple GLP-1s through the central nervous system, including the effects on the satiety, and it causes satiety for humans. So these were the main effects of GLP-1, pancreas, stomach, brain. But in addition, we now know that it also has effects on the liver, heart, blood vessels, kidneys, and the other body systems. This incretin effect that I earlier described is blunted in type 2 diabetes. So it was described that a reduced incretin effect in type 2 diabetes has been demonstrated. And this suggests either possible loss of beta cell responsiveness to the action of incretin or loss of incretin factors. The glia monster, this was described sometime in 1980. This is a species of venomous lizard in Mexico, which only eats 4 times a year. When it's fasting, it shuts down the pancreas, stopping insulin. When it's time to eat, it restarts pancreas with exidin 4, which is present in its saliva, which is a GLP-1 agonist. So to activate the necessary metabolic responses to its rare meals, the glia monster's saliva contains exidin 4, which is resistant to DPP4 action, thus allowing the islet cells to awaken from the predominantly inactive state. Exenatide was a GLP-1 drug that's a 39 amino acid synthetic peptide, which was based on exidin 4, and it's also DPP4 resistant. So this is the native human GLP-1. So this is the 30 amino acid peptide, as I described. This is native body human GLP-1. Due to rapid breakdown by the DPP-4 here and renal clearance, the half-life of circulating GLP-1 is only 1 to 2 minutes. There's only 10% of the native GLP-1 that's released from the L cells reaches the systemic circulation. Now, liraglutide, also known as Victoza, it resembles human GLP-1, but it circumvents DPP-4 degradation through an amino acid substitution, arginine for lysine at position 34, and also insertion of a fatty acid chain to lysine at position 26, resulting in liraglutide's association with albumin. With these changes, liraglutide has a half-life of about 13 hours, and that's why liraglutide is the drug that we still prescribe daily. So this is Victoza or Saxenda, which is the daily injection because of the half-life of 13 hours. Then came semaglutide, which also has a similar position of arginine here. It also has a C18 attachment for reversible bounding of albumin and an amino isobutyric attachment here. And because of this, the semaglutide half-life has been extended to 165 hours, allowing once-a-week dosing. This is 94% homologous to the human GLP-1, and the amino isobutyric substitution resists the degradation by DPP-4, allowing for once-weekly dosing. So semaglutide is what we know as Ozempic when prescribed for diabetes and Wegovy when prescribed for obesity. So this is how the native human GLP-1 was altered to make liraglutide and semaglutide with longer half-lives. A little bit about the timeline of the GLP-1. So it's in 1964 is when the incretin effect was described that I mentioned. The exidin 4 was identified in the glia monster in 1992. In 1992, they also showed that DPP-4 is what causes the inactivation. In 2005, the first injectable GLP-1 was licensed for type 2 diabetes. In 2014, first GLP-1 for obesity. And in 2019, first oral GLP-1 was approved for type 2 diabetes. In many of these steps of discovery, a very prominent scientist involved is Dr. Daniel Druckner. And I wanted to just let everybody know that he's going to be coming for grand rounds on April 24th to talk more about the discovery of GLP-1, who was actually involved in a lot of these steps. So that's Medicine Grand Rounds on April 24th. These are the years of FDA approvals of the different GLP-1s. So the 2005 was exenatide, which was very short acting, twice a day. Then in 2010 came liraglutide. 2014 came dulaglutide, also known as Trulicity. 2016 was lixisenatide. 2017 came semaglutide, also known as Ozempic. 2018 was extended release exenatide, and 2019 is the oral semaglutide, also known as Rybelsus, which is administered daily. So these are the different GLP-1 receptor agonists that have come and been FDA approved over the last several years. Now it's projected that we already know that there's a lot of diabetes currently, but it's projected to be even more by the year 2040. And we do know that the primary cause of death in patients with diabetes is cardiovascular. So about 66% of cause of death in patients with type 2 diabetes is due to some cardiac cause, such as sudden cardiac death, MI, heart failure, stroke. 33% is related to non-cardiovascular associated death. In 2008, cardiovascular outcome trial became an FDA requirement for approval of new treatments for type 2 diabetes, and similar requirement was put forth by Europe as well. The need for improved data on the cardiovascular safety of glucose-lowering therapeutics was highlighted after serious concerns were raised about cardiovascular safety of rosiglitazone. Hence, cardiovascular benefits of all GLP-1s have been investigated, except the exenatide, which came before 2008. So I'm going to now talk about some of the landmark trials for the GLP-1s for type 2 diabetes, obesity, cardiovascular protection, renal protection, and non-alcoholic fatty liver disease. So the first cardiovascular outcome trial was the LEADER trial, and this came out in 2016. They wanted to study liraglutide and cardiovascular outcome in type 2 diabetes. The patients they included here was patients with diabetes and A1C more than 7%. Either they were not on anything or they were on 2 agents or insulin. age older than 50 years with known cardiovascular disease or chronic renal failure, and age over 60 years with risk factors for cardiovascular disease. They were randomized to receive either liraglutide daily injection or placebo, and the mean duration was about 3.8 years. It was a global trial with 410 sites in about 32 countries, and this is the hemoglobin A1C reduction that was seen. And to remind you, this is an absolute value of A1C reduction. So by minus 0.4%, liraglutide lowered A1C compared to placebo at the end of about 42 to 48 months. They also saw weight loss of about minus 2.3 kilogram in the liraglutide group compared to the placebo group. So they did see statistically significant results for A1C and body weight for liraglutide. The primary outcome of this was a first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke in a time-to-event analysis. And they did see that the patients in the liraglutide arm had 13% lower incidence of primary outcome compared to the placebo, which was 14.9%. And so this was very exciting because this was the very significant study results of improving cardiovascular health in patients with type 2 diabetes with existing cardiovascular disease. To remind you, so this is daily liraglutide, which we currently prescribe as Victoza. We start at a daily dose of 0.6 milligram, and then every 2 weeks go to 1.2 milligram, and then 1.8 milligram. And the same drug, liraglutide, is also FDA approved as Saxenda for weight loss. So this was a very exciting study. And back then, we started using liraglutide or Victoza for patients with type 2 diabetes and established cardiovascular disease. Then came semaglutide, also known as Ozempic. And this was a SUSTAIN 6 trial later in the same year, where they studied semaglutide and cardiovascular outcomes in patients with type 2 diabetes. The inclusion criteria is same. So type 2 diabetes, A1C more than 7%, age older than 50 with known cardiovascular disease, or 60 with risk factors. And they were randomized to either receive semaglutide or a 0.5 milligram or 1 milligram and volume match placebo of 0.5 and 1. The median duration was about 2 years. And they had the same, they studied the same primary outcome, which was first occurrence of death from cardiovascular causes, non-fatal MI, and non-fatal stroke. And the results were even better with semaglutide here. So in the semaglutide arm, the 6.6% of the primary outcome, whereas in the placebo, it was 8.9%. So the composite primary event occurred in about 108 patients, 6.6% in the placebo group, in the semaglutide group, and about 146 or 8.9% in the placebo group, which was very statistically significant. And so this was, again, very, very exciting. And we started using semaglutide or Ozempic for diabetes in patients with cardiovascular disease specifically. So Ozempic is started at 0.25 milligram once a week. And then every 4 weeks, we go up to 0.5 milligram, then 1 milligram, which was the initial FDA approved. And now we can go up to 2 milligram dose. Even they also studied for non-fatal myocardial infarction and non-fatal stroke. And for both of these, we do see that there was a much lesser outcome in the semaglutide arm compared to the placebo arm, even for non-fatal MI and non-fatal stroke. This was the results for the hemoglobin A1C. And for the semaglutide 0.5 group, there was a minus 1.1% of reduction in A1C. Whereas in the semaglutide 1 milligram, it was by about minus 4.4%, minus 1.4%. So they started here at a baseline of 8.7%. This group lowered to about 7.6, whereas this group 7.3% of A1C. And similar results was also seen in the weight, where they started with a baseline of about 92 kilogram. In this group, they reached about 88.5, and here it was 87.2. So they lost weight about minus 3.6 in the 0.5 milligram group and minus 4.9 kilogram in the 1 milligram. So, and then we started using semaglutide as Wegovy for patients with just weight loss without history of diabetes. They also saw statistically significant results in lowering of systolic blood pressure. So the systolic blood pressure here at baseline is 135.6. In the 0.5 milligram semaglutide group, it lowered to 132.2. And in the 1 milligram group, it lowered to 130.3. So the reduction in systolic blood pressure was statistically significant for the semaglutide arm. In the diastolic blood pressure, there was no significant, statistically significant difference. At week 104, that was how long the study was done, the patients in semaglutide group, the mean pulse rate increased from a baseline of 72 beats per minute by 2.1 beats per minute in the 0.5 milligram semaglutide group and by 2.4 beats per minute in the group receiving 1 milligram. So there was an increase in the mean pulse rate in the semaglutide group compared to placebo. And this effect has been seen in all the trials. We have in all the GLP-1s, we've seen a slight increase in the heart rate, which is seen across class effect. So with that SUSTAIN 6, they studied semaglutide in multiple other trials. So all the semaglutide trials that were studied for diabetes are called SUSTAIN, and there are 7 trials. In each trial, so first SUSTAIN 1 was placebo, SUSTAIN 2 was versus sitagliptin or Januvia. Here it's with exenatide. SUSTAIN 4 is with basal insulin. SUSTAIN 5 semaglutide versus placebo. SUSTAIN 6 is semaglutide versus dulaglutide or Trulicity, and SUSTAIN 6 is the trial I just went through. And across, the light blue is the semaglutide 0.5 and the dark blue is semaglutide 1 milligram dose. And across all the trials, we do see that the reduction in A1C was much higher in the semaglutide arms compared to the other arm. Even in dulaglutide or Trulicity, you see that the effect of semaglutide or Ozempic in lowering the A1C was more than that of dulaglutide or Trulicity. So for those of you who want to know more about these trials, I encourage you to read the SUSTAIN trials. Similarly, they also studied baseline weight in all of these trials. And again, across all trials, we do see that the lowering of weight in the semaglutide arm or the Ozempic arm was much more than the one in the other study arm, which contain of other agents or placebo. Then came oral semaglutide, also known as Rybelsus. So until recently, all the GLP-1s were injectable subcutaneously, and oral GLP-1 would allow more wide use of this class, particularly in patients hesitant to take injectable formulation. However, formulating a peptide for oral administration brings considerable challenges in terms of protecting the active molecule during its passage through the GI tract and facilitating absorption across the GI epithelium. This is oral semaglutide, which is a co-formulation of semaglutide with an absorption enhancer called SNAC, sodium N8 hydroxybenzoyl amino caprylate, SNAC. And this is the first oral GLP-1 that has been approved for clinical use in type 2 diabetes. So SNAC has also been previously co-formulated with heparin and ivandronate and vitamin B12. So it helps to protect semaglutide from the proteolytic degradation in the stomach and facilitates its absorption across the gastric mucosa. SNAC itself is eliminated after 4 to 6 hours. The presence of food and substantial volumes of water in the stomach reduces the gastric absorption of oral semaglutide. So in clinical trials, patients were required to take semaglutide first thing in the morning with no more than 120 ml of water and wait 30 minutes before taking any food, drink, or other oral medication. So for the oral semaglutide, also, they wanted to study whether it had the cardiovascular data that the injectable semaglutide had. And this study is the Pioneer 6 study. The aim was to assess cardiovascular outcomes of the once daily oral semaglutide, also known as Rybelsus, in an event-driven, randomized, double-blinded, placebo-controlled trial involving patients with cardiovascular disease. The primary outcome was the same: time from randomization to first occurrence of cardiovascular event, a composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. The trial was an event-driven trial designed to rule out an 80% excess in cardiovascular risk with oral semaglutide by assessment of non-inferiority to placebo for the primary outcome. A total of about 3,000 patients were randomly assigned to oral semaglutide 1500 and placebo 1500. The median time was 15.9 months. The primary outcome occurred in 61 patients out of 1,500, which was 3.8% receiving oral semaglutide, and 76 patients, so 4.8% receiving placebo. Thus, non-inferiority was confirmed for oral semaglutide as compared with placebo, but superiority was not achieved. So it did not demonstrate superiority. They further looked into it, and they said that there was a similarity of the hazard ratios in the Pioneer 6 trial and the Sustain 6 trial. And so they thought that the cardiovascular effect of semaglutide is independent of the administration route. However, this study did not show superiority, although it just demonstrated non-inferiority. Since then, there have been some meta-analysis suggesting that the effect is class-driven, and they said that this study was just ruled out excessive cardiovascular risk with oral semaglutide. It therefore had fewer patients, shorter in duration than to-be required, and hence maybe that's why it did not show superiority. Clinically, this is not my first choice when I have to prescribe a GLP-1 receptor, and the reasons being that one, it didn't show superiority in the cardiovascular trial. There has been no head-to-head trial of oral semaglutide versus injectable, but in certain meta-analysis, I think the efficacy is lower compared to Ozempic. Also, it's a daily dosing. You start at 3 milligram daily, then 7 milligram, 14 milligram, 21 milligram. You have to take it in a fasting state and wait for 30 minutes before a meal. So clinically, it's not my first choice. However, this is something where shared decision-making with the patient comes in place, where if there are certain patients who do not want to take an injectable or who do not tolerate the injectable, and for those patients, I do switch them to oral semaglutide or Rybelsus. However, for patients who don't mind an injectable or who don't have a preference, I usually go with the injectable semaglutide or Ozempic. Building on the experience of semaglutide in diabetes, then they wanted to study semaglutide for patients with obesity without diabetes. And so this was a STEP program, and here they had 5 trials, step 1 to 5. The patients eligible here were older than 18 years with BMI more than 30 or BMI more than 27 plus some complications. They were either on semaglutide or placebo. In step 1 to 4 and 5, they had lifestyle intervention. Step 3 had intensive behavioral therapy. In all the trials, the dose was escalated every 4 weeks, 0.25 milligram, then 4 weeks later, 0.5, 1 milligram, 1.7, and 2.4 milligram. And this was the STEP program. Step 1 was a randomized double-blinded placebo-controlled trial at 129 sites in 16 countries. Patients were randomly assigned to receive semaglutide at a dose of 2.4 milligram versus a placebo over 68 weeks, in addition to lifestyle intervention. And you'd see here that the weight loss seen in the semaglutide 2.4 milligram was minus 14.9, so 15% of weight loss compared to minus 2.4% of the placebo arm. And you'll see that this weight loss is much more than what I showed you in the Sustain 6 or Ozempic trial, but the dose used there was 1 milligram, and the dose used here for obesity is 2.4 milligram. And so the 15% of weight loss was seen, which is equivalent to 15.3 kilogram. And more than 86% of patients lost more than 5% weight, 69% lost more than 10% weight, 50% of patients lost more than 15% of weight, and 32% lost more than 20% of the weight. So the weight loss seen in the step 1 was phenomenal. And so this drug is now used as Wegovy for patients with obesity without the history of diabetes. In this trial, most participants were females with a median age of 46 years and BMI around 37.9. They also studied physical function with semaglutide, and these are physical functioning scores. And what they saw in the step 1 trial was that as in the semaglutide arm, as patients lost weight, they improved their physical functioning scores. This is a very interesting step 4 trial. Here, what they wanted to do, so in the beginning here, they enrolled patients, about 900 here, and put them on semaglutide 2.4 milligram. At 20 weeks, so they'd lost about 10.6% weight here. At 20 weeks, half of them were then switched to placebo, whereas the remaining continued semaglutide. And you'd see that the arm where semaglutide was continued, they continued to lose 7.9% more weight. So in total, they lost about 18% of the weight. However, those patients at 20 weeks that was switched to placebo regained the weight and then gained about 6.8% of the weight at 68%. So for the patients where semaglutide was withdrawn or switched to placebo, there was a weight regain effect seen. And this trial brought to light the importance of treating obesity as a chronic disease and the necessity for lifelong treatment, because this is not something that you can do for short term, as it will lead to weight regain on withdrawal. And this is something that we see clinically also all the time. I'm sure many of you have seen that when you withdraw these agents, there is a weight regain seen, and that's why we need to emphasize on the chronic treatment of obesity. In step 5, they wanted to study the shift in glycemic status. So here, at the beginning of the semaglutide arm, about 50% had prediabetes, but at week 104, only 20% of them had prediabetes compared to the placebo arm, where more patients develop prediabetes and some develop diabetes. In the semaglutide arm, about 50% here were normal glycemia, but then this number went up to 98.6% in the placebo arm, and it was lesser in the placebo arm. So it was more in the semaglutide. So there was pre-diabetes became normal glycemia in patients in step 5 on semaglutide. Step 8 trial wanted to compare liraglutide or 3 milligram daily, which is the Saxenda that we use for weight loss, versus semaglutide 2.4 milligram weekly, which we use as Wegovy for weight loss. And they saw that semaglutide, the weight loss was 15.8% compared to liraglutide or Saxenda, where the weight loss was 6.4%. So much more weight loss seen in the weekly Wegovy compared to the daily Saxenda. Having said that, do I still have patients in Saxenda? And the answer is yes, because a lot of times it's also insurance driven. So, many times if Wegovy is not covered, but if Saxenda is covered, then, I do prescribe Saxenda. It's a daily injection, but it still shows 6.4% weight loss. And there are patients who tolerate it, who don't mind the daily injection. So a lot of it, so even though Wegovy is excellent, Saxenda is still good. But off late, there have been a lot of issues in getting Saxenda due to supply chain issues. And so similarly to SUSTAIN, they did many step trials in different kind of population, in type 2 diabetes, with intensive behavioral therapy, with sustained weight management. This is the withdrawal trial, with East Asian population, head-to-head with liraglutide. And again, across the trials, you see that patients in the semaglutide arm lost much more weight compared to the other arm. And this is where it was withdrawn and the patients actually gained weight. So those of you who want to study more about these weight loss trials, I encourage you to reach the STEP trials. Now moving on, so we covered diabetes, obesity. Now moving on to liver or non-alcoholic steatohepatitis. So this was a 72-week double-blind phase 2 trial involving patients with phase 2 biopsy-covered confirmed NASH and liver fibrosis of stage F1, F2, or F3. Patients were randomly assigned to either receive semaglutide once daily at dose of 0.1, 0.2, 0.4, a corresponding placebo. Primary endpoint was resolution of NASH with no worsening of liver fibrosis. Secondary endpoint was improvement in fibrosis stage with no worsening of NASH. So in a total of 320 patients, of whom 230 had about stage F2 or F3 fibrosis, they were randomly assigned. And you see that the percentage of patients in whom NASH resolution was achieved was 40% here, 36%, and 59%. In the semaglutide arms compared to 17% in placebo. And so this was statistically significant resolution of NASH. However, for the improvement in liver fibrosis stage, the trial did not show a significant between group difference in the percentage of patients with liver fibrosis. So this secondary endpoint was not achieved. However, the primary endpoint of resolution of NASH was achieved with semaglutide. So, and I think that more trials are currently underway to study further the effect of semaglutide and NASH. But clinically, if I do have patients on NASH, I prescribe them semaglutide, and I have seen definitely improvement in the liver enzymes. Moving on to renal, so effect of semaglutide on albuminuria and kidney function. So there is no study yet completed and published for the renal outcomes of semaglutide. This study is a post hoc of step 1 to 3 trials, which I just reviewed, the semaglutide and weight loss. So this is a post hoc analysis of that. And then what they wanted to, this is the semaglutide 1 milligram arm, 2.4 milligram arm, and placebo arm. And what they did see that there was improvement in the urine microalbuminuria in the semaglutide arms. However, there was worsening in the placebo arm. Similarly, they saw that patients in the semaglutide arms had improving albuminuria, which was not seen, of course, in the placebo. So there's some data of improvement of microalbuminuria and proteinuria in patients with semaglutide compared to placebo. There is a flow trial that's been currently, I think it's completed, but we don't have the results yet. So This is the FLOW trial, which is a kidney outcome trial with once-a-week semaglutide in patients with type 2 diabetes and chronic kidney disease. The patients that they enrolled here were type 2 diabetes, GFR 50 to 75, and even GFR 25 to 30, urine microalbumin between 300 and 5,000. And their primary endpoint is time to first occurrence of kidney failure or persistent 50% reduction in GFR or death from kidney or cardiovascular causes. The patients enrolled in this, the baseline characteristics are high-risk CKD, urine microalbuminuria of 568 as a mean, and GFR of 47, advanced type 2 diabetes. This FLOW study was actually terminated earlier in October 2023, and the decision to stop the trial early was based upon the recommendation from Independent Data Monitoring Committee, concluding that the results from interim analysis already met certain pre-specified criteria for stopping the trial early for efficacy. So the trial already showed great results and had to be terminated in October 2023, and I think the results are going to be published some point in 2024. So for the renal outcome, we stay tuned. Moving over to cardiovascular, so semaglutide and cardiovascular outcomes in patients without diabetes. So last year, this SELECT trial got published, and for those of you in the cardiology world, have heard a lot about this. So here, they studied semaglutide in patients older than 45 years with pre-existing cardiovascular disease, BMI more than 27, but they had no history of diabetes. They were randomly assigned 1-to-1 ratio to receive once a week semaglutide 2.4 or placebo, with the median duration being 39.8 months. The primary outcome was the same composite of death from cardiovascular causes, non-fatal MI, and non-fatal stroke. A total of 17,000 patients underwent randomizations, 8,800 in the placebo group and 8,800 in the semaglutide arm. The primary cardiovascular endpoint occurred in 6.5% in the semaglutide group compared to 8% in the placebo group. And so this result was statistically significant. You would also see that the result, the difference between the two arms starts very early in the trial and then continues. So the primary endpoint was met, and there were fewer events in the semaglutide arm compared to placebo. Death from the cardiovascular causes, which was the first confirmatory second endpoint, occurred in 2.5% patients in the semaglutide group versus 3% in the placebo. The between group difference with respect to death from cardiovascular did not meet the required p-value for hierarchical testing, and so superiority testing was not performed for the remaining endpoints. But the effect of semaglutide occurred very early in initiation of treatment. Primary outcome was met. There's a lot of hypotheses and postulations right now regarding the mechanism of cardiovascular risk reduction in semaglutide for those with existing cardiac disease. It could be the loss of excess of abnormal body fat. Different other actions are currently postulated, and many studies have been underway to study this exact mechanism of the effect of semaglutide in reducing cardiovascular. Now moving on to adverse effect, because this is something that all of you must have clinically encountered a lot. So GLP-1s, irrespective of their half-life, they do have side effects. They're usually transient, typically during the dose escalation period, and they generally resolve soon. Most common, there are all these trials showed similar adverse effects, but I picked the step 8, which compared semaglutide 2.4 versus liraglutide 3 milligrams, so that we get a perspective of both these drugs. The most common side effect is gastrointestinal. So nausea, constipation, vomiting, diarrhea, headache, irritation. I see it in majority of my patients. GI side effects are seen. In the liraglutide arm, they saw more of fatigue and dyspepsia. But as I said, they're usually seen when we start the drug or when we increase the dose. They're usually short-lived for a couple of weeks, and then the patient is able to manage them, or they're not of the same intensity anymore. The other side effects that were seen in the liraglutide or Saxenda arm was also psychiatric, which was more insomnia was seen. Some injection site reaction was seen. Gallbladder disorder seen more in the liraglutide group. Gallstones was similar across. Acute pancreatitis just occurred in one patient in the liraglutide arm. And then the other in the cardiovascular disorders, which you see 12%, 14%, is the change in the heart rate. As I said, it was 5.4 beats per minute seen in the semaglutide and 4.3 beats per minute in the liraglutide. And this increase in heart rate is due to direct stimulation of sinoatrial node, as GLP-1 receptors are located in the sinoatrial node cells in the monkeys and human tissues. So these are the most common side effects. Now, how do we manage? Because I would say almost 70 to 80% of my patients have gastrointestinal side effects, and the others have the rarer side effects. At the first visit, it's our job to educate and explain and let them know that these side effects will happen: nausea, constipation, diarrhea, vomiting, fatigue, headache, but also tell them that they could be mild. They usually occur when we increase the dose. They can adjust the diet, have smaller portions of meal, have lesser fat content, change the diet to help them manage the side effects. Also titrate the dose appropriately. You start at the lower dose. Even though the trials went up every 4 weeks, we don't have to do that clinically. If patient already has side effect on the lower agent, then we can wait another month or another 2 months before you go up on the dose. Once we go up and they have more side effects, it's okay to go back down on the dose. Use a drug that's effective and tolerable. Individualized approach to every patient, and stay on the dose that they can manage their side effects. Some of the side effects can also be treated symptomatically with over-the-counter Pepcid or famotidine or PPIs I've used for some patients, and they then are able to tolerate the GLP-1s better. Very important to review the history at the beginning, at your first visit, whether they've had a pancreatitis, whether they had gastroparesis, history of medullary thyroid cancer in family, before we start the agent. There are very few contraindications, but we must go through them at your initial visit before prescribing the drug. So I would say that, yes, there are side effects, but most of them are manageable when done the right way. I will now talk about a case to describe how to switch between GLP-1 agonists. So this is my patient. He's a 56-year-old male with history of diabetes and hemoglobin A1C 8%. He has a history of cardiovascular disease status post-stent. His current medications are metformin, empagliflozin, or Jardiance, and dulaglutide or Trulicity. So when I saw him, he has the past history of cardiovascular A1 disease. He had an elevated A1C. We know from the trials that Ozempic or semaglutide has shown cardiovascular outcomes. So then I switched him from dulaglutide. He was on the maximum dose, 4.5 milligram, but we know that semaglutide is more potent. So I switched him to the 0.5 milligram dose, and then I gradually increased him to 1 milligram and 2 milligram weekly. At the follow-up visit in 6 months, his A1C had come down to 6.6%, and he lost 15 pounds of weight. So when you know that there is a better GLP-1, there is an indication for that, then you can switch them to a more potent GLP-1. And how do we switch the doses? There's some guidance here this table gives, where if they are on the lower doses of liraglutide or oral semaglutide, these are the least potent. So if they're already on 1.2 milligram of Victoza, then you can start lower dose of Saxenda or Ozempic or Trulicity. Or tirzepatide or Mounjaro is also something I wanted to include here, but this is roughly a table that helps you to how to switch to an equivalent dose of GLP-1. What are some of the indications for switching them? One is if you need better glycemic control, better weight control, or if they have coronary artery disease and you want to switch them to semaglutide for cardioprotection. Sometimes they may not tolerate injectable, and then you switch them to the oral semaglutide, or sometimes patient preference. There's so much out there that sometimes patients come to me with preferences that I want to be switched to this agent, and then this table roughly gives you an idea on how to do it. In the last year, we saw this a lot in the news. We saw this Ozempic phase at Oscars, the name on everybody's lips. Anesthesia raised some risks. People said that Walmart is losing money because patients are not eating as much. Airline industry is going to save money because of weight loss. So I think that in all of these noise and all these news, we clinicians hold a very special role and responsibility to guide the patients and public regarding the appropriate use of GLP-1. GLP-1 receptors are excellent agents when used in the appropriate indication: diabetes, obesity, cardiac disease, NASH, in the right patient, after reviewing all the side effects, carefully reviewing the history. In the right patient, it's a wonderful agent. However, of late, there's a lot of been misuse used in patients who don't need it with a lower BMI to just lose more weight, use of compounded medications, which is not FDA approved. And all of these things have led to these news. However, when appropriately indicated, GLP-1 phenomenal response. So appropriate indication is your type 2 diabetes with or without heart disease, nephropathy, non-alcoholic fatty liver disease, obesity for medical weight loss management, patients with diabetes who are awaiting organ transplant and need to lose weight, or even post-transplant, patients with obesity who are awaiting gastric sleeve surgery, The choice of agents is again often dictated by insurance, by patient preference, adverse effects, and tolerability. So all of these agents do come. You always want to prescribe with the one that you think is ideal, but then there could be some switching around based on other factors. And always review the history, document the contraindications very well before. It's not an agent for every patient, but just for the appropriate patient. Future directions, so there's a lot coming up. So GLP-1 was just one receptor. Now there are dual receptor agonists, which is GLP-1 glucagon and GLP-1 GIP, which has shown better glycemic control, body weight loss. There's also a triple agent, which is GLP-1, GIP, and glucagon, which is going to show better weight loss, glycemic control, hepatosteatosis, energy expenditure. So tirzepatide or Mounjaro is a dual agonist. So that's was approved by FDA in 2022. So this was the SURMOUNT-1 trial for the weight loss that was seen in tirzepatide and Mounjaro. Just to give you a snippet of it, the doses of 2.5, 5, 10, 15, and you see that the highest weight loss that's seen here is about 20%. So, in semaglutide of Wegovy, we saw 15%. Here, the weight loss that tirzepatide saw was 20% of weight loss. So some phenomenal improvement in A1C, weight loss, as well as cardiovascular risk factors. Triple agonist is also known as retatrutide. Currently, we just have a phase 2 study. This is GIP, GLP-1, glucagon, triple hormone receptor agonist. The phase 2 study showed 25% of weight loss, so even more than what tirzepatide showed us, which has an average weight reduction of 26 kilograms or 58 pounds. So a lot more exciting agents are coming up. I wanted to end with a very, very simple case, something that I see almost every day in my clinic. So he's a 38-year-old male referred for high blood pressure, for diabetes. He has high blood pressure and hyperlipidemia. He was diagnosed with diabetes in February 2022 with A1C of 14%. He was started on metformin and insulin glargine. He established care with me last year in February 2023. A1C was 8.6%. He had some proteinuria, hyperlipidemia, no cardiac disease. So at this visit, I just added weekly semaglutide or Ozempic. At subsequent visit, I increased semaglutide and I was able to stop the insulin glargine. What I wanted to show you is that I just prescribed semaglutide for the indication of type 2 diabetes, and I saw that that was achieved. A1C improved from 8.6 to 6.6. He had some mild microalbuminuria that resolved his weight. He lost 23 pounds from 163 to 140. All the values, total cholesterol, LDL, triglycerides came down, and HDL went up. So even though the indication is type 2 diabetes, we do see that all the metabolic parameters, nephropathy, weight, cholesterol, systolic blood pressure, all of these improve with the use of GLP-1. And I wonder if by prescribing them, we're actually preventing future cardiac diseases as well. So to summarize, GLP-1 agonists have proven efficacy, and I reviewed with you some landmark trials for diabetes, obesity, cardiovascular disease, non-alcoholic fatty liver disease, and nephropathy. Excellent agent when prescribed for the appropriate indication. However, I urge everybody to review the history carefully, to review the adverse effects carefully, go over the contraindications, and then prescribe it for the right age, for the right indication, titrate it slowly or as the patient tolerates it, and then you're going to see wonderful results for your patients. And with that, I would like to thank for this opportunity of presenting. It's a huge topic with lots to cover. I've tried my best to summarize this in 40-45 minutes to help to show some great data as well as the use in daily clinical work. Thank you. And with that, I'm open to questions.
Thank you, Dr. Desai. I want to get right into questions. Usually we have a couple and then a bunch come up. We already have 12. We have a lot of questions coming as expected. So please, everybody, upvote. Thank you for those who've already been upvoting questions. And I'll prioritize those and try to get to as many as possible, including combining a number of questions. I'll start with Dr. Knowles. Great talk. Thanks. What about the reports of decreased muscle mass? This question's come up by a few people on these drugs. Is it getting, also he's wondering about it easier to get insurance to cover, does medical cover? Dr. Marin had also asked about the concern for muscle loss. Nick Leeper and Dr. Leeper also mentioned in the chat a lot of questions about muscle loss. Should older patients, Marin asking, not be on these medications?
Yes, so there is some data now coming up. There are some studies suggest studying muscle loss as well as sarcopenia or bone issues in patients with GLP-1 because they do lose a lot of weight. And I think that's coming, and we're going to see that soon resulted in trial. My suggestion to my patients is that to increase some kind of physical activity, to begin CrossFit or begin Pilates or some kind of physical activity in their daily 30 minutes to 45 minutes, but do something for strength training or muscle training as part of this, because we do know that there is some kind of muscle loss as well as even sarcopenia seen. So yes, but the benefits are so high. So to combat this adverse effect, my suggestion is to just increase strength training and muscle training in your daily physical.
Are you seeing it? Josh is also asking about insurance coverage. That's been tough. I know Eli Lilly is starting this direct to consumer, but then insurance affects that.
It's very tough. I'll tell you that for diabetes, it's very easy. All the insurance companies do cover some GLP-1. So though you start with Ozempic, if it's not covered, switch to Mounjaro, liraglutide, or Victoza, Trulicity. Some GLP-1 is covered for diabetes patient. Diabetes is not a problem. The problem is just for weight loss without diabetes. And some insurances just don't cover obesity. So I prescribe it, then we do appeals. My staff does a lot of peer-to-peer and prior authorizations, and Medi-Cal covers Wegovy. So it's a hit or miss. We try our best, document carefully. Patients can themselves appeal. So a lot of my patients are their own advocates, and they themselves appeal to the insurance company with their weight history, with the benefits, and they get it approved. So it is a lot of work, but I think that hopefully, the manufacturers understand that and the coverage opens. There's also a lot of, in the Endocrine Society, Obesity Society, there's a lot of advocacy at Capitol Hill to approve these agents for these patients. So hopefully in the coming future, we would have lesser and lesser of.
Great. Dr. Sushman has asked, when used for obesity, I've seen weight loss efficacy, such with Wegovy over time, and then regain some weight, as you showed. How do you see this, and when do you switch to tirzepatide, the Mounjaro? And the other question is, if weight loss is achieved and maintained for 8 to 10 months, does the body recognize some sort of set point? Is there therefore minimal weight gain if the medication stops? We wanted to confirm. The study didn't seem to show that. I don't believe that's the case, right? There's no point where you can get off it and not gain the weight back, is my understanding.
Yeah, excellent questions. And I think that at my first visit of the weight loss, my first 20 minutes are spent in lifestyle. I talk to them a lot about what they should do in terms of their diet, calorie restriction, intermittent fasting, choice of food. So I do emphasize a lot on diet at the first visit as well as every visit, and also physical activity at 30 minutes daily. And I tell them that the drug will only act so much. If you don't do physical activity or change your lifestyle, it's not going to help us as much as it's supposed to be. And so sometimes I don't even prescribe the drug at the first stage, and I make the lifestyle for 3 months so that they are on that, and then we prescribe medication. If they lose weight at the maximum dose of Wegovy. If they plateau or they're not losing any more weight in spite of physical activity and lifestyle, that's when I switch to Mounjaro, which is now Zepbound approved for weight loss. So at the maximum efficacy of Wegovy, when there's no further weight loss, that's when we switch to Zepbound. Now we directly prescribe Zepbound as the first agent since it's FDA approved. In terms of weight regain, yes, the trial showed weight regain when we stopped it. The obesity set point does come down. So with the help of fast calorie restriction or better eating or physical activity and losing weight, the body does get adjusted to a little bit lower obesity, but they have to be consistent. They have to be consistent with lifestyle as well as medication over some time. Most patients do regain. However, I do have some women patients, and I say that women because I think they're more determined, who want to get off the agent. They tell me that, okay, I've received my weight. I want to now get off. I don't want to be on this agent forever. And what I tell them is the weight loss is just achieved by calorie restriction. The drug is not doing anything. The drug is just reducing the satiety, reducing the intake. So the patients eat less. So they eat, say, 1,000 calories where they were eating 2,000 calories. Now, if they want to come off the agent, and if they can maintain that 1,000 calorie food intake with the physical activity and lifestyle, they can maintain the weight. However, if their calorie intake goes back to what they were, they're going to regain the weight. So I do educate my patients, and I do have some patients who are very determined, very motivated, love their new lifestyle, and then they are able to, maintain that. Very few of them, but they're able to come off it and maintain the weight. The other trick I do is then you can come down also. You can come down on the lowest tolerable dose and stay on that dose, which helps them to maintain. Many times patients come to their goal weight. They don't want to lose more. They just want to stay here. And then we find a maintenance dose to kind of have them on that dose for long.
Got it. Thanks, Dr. Salman, for mentioning Medi-Cal covers, including Wegovy. Dr. Golden asked, for the most standard type 2 diabetes, should we still start metformin first? That's still, right, insurance doesn't necessarily cover all diabetes, has to be a certain, right?
Yes, I think first agent should be metformin. If you start GLP-1, we're going to get back the insurance will say that patient has not been on metformin or not tolerated. They want some documentation about metformin before they prescribe or approve GLP-1. So metformin is still the one, the guidelines, ADA, it's still metformin is the first line, GLP-1 is second for now. So I would still do metformin, it also helps in insulin resistance. So first metformin, then GLP-1, at least now in clinical practice.
Dr. Lafayette, is there any cardiovascular benefit if no weight loss or BP change? I don't know if that's been.
I don't know. That's not really been studied. And all these studies, they saw everything together. It's reduction in blood pressure, cholesterol, weight, A1C, and cardiovascular outcomes. So I don't know if without, I have very few patients who've not lost weight. Most people lose weight. Most people respond very well. There are a couple of non-responders who don't lose as much weight, but I do not know I don't know if that's been studied. I don't think it's been studied.
Got it. Dr. Marin, please comment on the relative efficacy on side effects of tirzepatide and Mounjaro.
You mean the side effects for tirzepatide or Mounjaro? It's similar side effects. GI side effects was the most: nausea, vomiting, constipation, diarrhea. So those, the class effect is similar to GLP-1.
Dr. Vasquez, great talk. When do you choose to start tirzepatide instead of semaglutide? A little more efficacy.
Yes.
Do you notice class drugs that have the GLP-1 but also GIP agonists? Is that probably driving?
Yeah, tirzepatide or Mounjaro has shown better hemoglobin A1C as well as weight loss. So I do prescribe sometimes if they're obesity with type 2 diabetes. I do sometimes use Mounjaro as my first agent. But I think irrespective of what we do, it's also insurance driven. Insurance may just cover Ozempic or may cover Mounjaro. We're just used to doing more Ozempic, but you're okay to start first line Mounjaro for type 2 diabetes or to start Zepbound as first line for obesity as long as the insurance covers it.
These are really interesting. Dr. Shi, there's been a lot of talk about changing your ability to affect addiction. Do you have a sense of research or whether there'll be a role for this in treating substance addiction?
Oh, I've not come across that. That's a very interesting point. And, maybe physiologically, yes, because it does reduce some kind of cravings. But I've not come across any study or any thought about use in substance.
Okay, thank you. More clarity on that.
Yeah.
Drug-induced, Dr. Cartwright, is drug-induced gastroparesis reversible if the drug is stopped?
Yes, I've seen that, correct. So if they have drug-induced gastroparesis, we stop it and the patients usually feel better. The problem is when they have existing gastroparesis. A lot of type 2 diabetes patients have existing gastroparesis, and I tell them at the visit that this may worsen, and a lot of them tell me that let me try. I understand the risk, and if it worsens, we'll stop it. But if it's mild to moderate gastroparesis, we do sometimes try if they have obesity or they have compelling factor for GLP-1. And sometimes I've seen no worsening effects, sometimes I've seen worsening. So if it worsens, we stop. But again, a conversation with the patient is essential before we start GLP-1 for gastroparesis patients.
Dr. Lieber, how about the essential effects beyond insomnia? Any reduction in the ability to enjoy food or any other activities?
Yeah, I think that they do, along with reducing your cravings and increasing your satiety, they do enjoy food a little less. Also, certain foods that they do not enjoy as they used to enjoy. It's mostly the portion control, but I have heard some patients, they don't enjoy that food that they used to, and that's helpful to them to avoid eating more calories.
Have you noticed beyond activities, this general enjoyment reduced in any way anecdotally, perhaps discussing with patients?
I think I've seen only in liraglutide or Saxenda. Nobody has told me on Wegovy or Ozempic, but in liraglutide, and they did see some kind of, I think last year there was also news of depression. I've had some patients tell me on liraglutide that they felt a little bit, they're enjoying a little less or felt a little bit depressed affect. Very few, handful of patients, like I can count them on my fingers, but nothing has been published yet or nothing has been proven yet in that. But I do have a couple of patients who did say that too.
Got it. Dr. Wang just notes, as GI anesthesia societies disagree, we do know that the true frequency of aspiration risk under anesthesia sedation with these patients. So any comment on that? So I guess with
yes.
the
Yes, I think that the anesthesia society was concerned about it, and they have been telling patients to stop a week before. Again, there's been no trial that's published or concluded or no guidelines telling us to do that yet. I don't think that risk is real. However, patients that are going to anesthesia have been asked to stop a week, and that's all right. Clinically, that's all right if they have to stop a week before the procedure, and then we start it again.
Right. Another question that seems to touch on addiction risk, and again, not well that's understood, but a fantastic talk and beautifully presented slides, and thank you. I had an overweight patient, not morbidly obese, requested semaglutide to help with alcohol use disorder before findings showed it may decrease alcohol use. Now there's a mention of possible utility of GLP-1 in reducing alcohol intake. There seems to be an activity on reward in the pathway of the brain. This isn't just suppression of appetite, but also suppresses desire to drink alcohol. Have you seen that with GLP-1 alcohol use? Again, this addiction thing that it's come up a lot in news and what people wondering if it is, but it's not fully tested.
Yeah, not fully tested, not fully resulted or published, but it does reduce your satiety. So I have my patients who were drinking, say, 4 drinks, now just drink a glass of wine, or they have reduced their alcohol intake. They feel full faster. They do also experience some more GI side effects with alcohol while on GLP-1. So I have seen reduction in alcohol use, but I'm not sure how much of that is satiety versus how much of that is from the reward behavior reduction, because nothing has been really proven in that field.
Dr. Al-Hajani, can you speak more to the psychiatric side effects on these drugs?
No, nothing really. I have not experienced any psychiatric effects, especially except for the couple of patients on liraglutide who mentioned a little bit low mood or low affect. No other psychiatric effects. And if anything, this drug has been great for patients with mental health disorders on antipsychotics who gained a lot of weight over the years because of the antipsychotic side effects. Now on GLP-1, they lost weight and they really feel better. And in fact, it has helped improvement of their mood just from the weight loss perspective.
Dr. Golden asks, how long do you keep a patient on a PPI for side effects? It kind of depend on their symptoms.
Yeah, depends on the symptoms. I tell them we have to do it short term. We have to give it a trial, and then if they tolerate it, then start scaling back and see how it goes. Also, it's once a week side effects. So sometimes they may just need the first or 2 days that they've taken it, but not necessarily the entire week. And then in that case, I also refer to GI to kind of have a co-management in that sense.
If it's okay, I'll just go a few more minutes. I know we're at 9:01. Do you mind?
I'm okay. I'm okay.
Thank you. Dr. Friday asks, do you use these agents on patients on insulin? And if so, how do you manage these?
Absolutely, all the time. So a lot of patients with type 2 diabetes are on insulin, and then I start with them, and the day I start the lowest dose, I do cut down their insulin doses by probably 10% to 15% based on how sensitive they are. As we titrate up the dose, I keep scaling back on the insulin. And I've seen that we are really able to come off, reduce the dose of insulin. Now, you do want to check their C-peptide to make sure that they make insulin. So, because if they don't, you don't want to necessarily stop it. But if they have enough C-peptide, then you can, as you increase GLP-1, you can even come back or stop the insulin altogether. Even in type 1 diabetes, GLP-1 is used off-label use. It's not approved yet by FDA, but several type 1 diabetes patients on insulin also have obesity. So several endocrinologists use it as off-label GLP-1, and we're able to come off their insulin.
Dr. Kaki, thank you for the excellent talk. We see a lot of patients on androgen deprivation therapy for prostate cancer gain weight and have cardiovascular complications. Should we be exploring starting using these drugs preemptively in starting patients on an ADT? And I have like 20 questions myself, which I won't ask because I'm prioritizing everybody else's, but one I may tack on. We're seeing all the reversal of things associated with obesity. There's also been associated obesity and cancer. Do you think that we'll see in the future that GLP-1 agonists may also reduce risk of certain cancers?
We do know that obesity is a risk factor for cancer, several cancers. We already know that. So I think that for patients with obesity who meet the criteria and we put them on GLP-1, maybe, yeah, we are reducing some future incidence of cancer. But again, nothing is studied. But I think, yes, I mean, we definitely know obesity is a big risk factor.
We may see, for Dr. Kaki's question too, just preemptively on certain risk populations, we might even see that down the line, exploring use drug.
Yeah, I think for now, we just have to look at the clinical. Do they have diabetes? Is their BMI high? Or other indications that have already been studied, and use it for a wider population that meets those criteria for now.
Got it. Dr. Razavi, given chronicity of these conditions, any data on long-term side effects?
Not yet. Yeah. I mean, the Victoza it's been out since early 2000s. So we've already been about 20 years now. And no long-term side effects that's reported yet. But I think that in coming years, they will publish. I'm sure somebody studied long-term effects of these. Nothing yet that we know of.
Great. Dr. Georgie, is the curtain reg still to start the GLP? agonists is instead of insulin in newly diagnosed diabetes, we start metformin, but in patients who clearly need something higher.
Yeah.
You sometimes just go to this instead of insulin?
I keep the cutoff of A1C as about 10%. So if the A1C is higher than 10%, 12%, 14%, newly diagnosed diabetes, they do need some basal insulin at that point. But then as they improve and the A1C comes down, I put them on GLP-1 and then stop the insulin. So certain really hyperglycemia, 13%, 14% insulin is the choice. But newer diabetes where it's 8%, 9% with obesity, it's okay to do metformin and GLP-1.
Dr. Anybody looked at increased thyroid T3, T4 with these drugs?
Increase what, sorry?
Just T3, T4 thyroid hormones.
That's not been studied. That's also very controversial. What we do see is that patients on levothyroxine, their doses come down as they lose weight. We also think that it's better absorbed when the patients are on GLP-1. So all my patients on levothyroxine, we have to reduce their doses as they lose weight on GLP-1, but the T3, T4 has not yet been studied.
We're hitting 5. Thank you for staying so long. I apologize. It's just you actually got maybe a new record, a number of questions answered. And certainly, I just also wanted people to know you're relatively new with us, and you are an in-house expert. Clearly, after this time, it's a very obvious expert in these drugs, and it's only going to become more important. Can I, as we close, can I ask you, as you pointed out beautifully, some of the highlighted things in the news, the effects that people are believing that this drug will have, may have. Your senses, the senses is a miracle drug. Do you feel like it really is just going to change the future of medicine in all the ways?
I think so, and I think so. And I've been doing this now. I've been practicing since 4 years alone as sole faculty endocrinologist, and prescribed it in so many patients with obesity and, liver enzymes sky high, cholesterol in 300s, hypertension. And over the years, I've seen that they really get better, like A1C, weight loss, cholesterol. All of the labs, when I get it, there's no color. It's all plain normal results now. And I've seen that over many, many, many patients now. So I do think that it is a great agent. And I'm thinking that it's the more we prescribe for the appropriate indication, the more we are going to prevent future cardiac events or future even cancer for that reason. I think it's a great, excellent agent. And I've seen phenomenal results in majority of my patients. Very few of my patients have discontinued because of adverse.
Wonderful. Well, thank you again for staying so long. Thanks to everybody who stuck with us. And you are welcome to come back as much as you want, as often as you want. This is a huge, huge topic, and we're looking forward. Hopefully, you'll join us with Dr. Drucker in April as well. And thanks so much for being with us.
Yes, thank you. It was great. And thank you, everybody, for this opportunity. Feel free to email me if anybody wants to reach out.
Thanks for offering that.
Yeah.
Everybody, rest of the day. Thank you. Bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.